Welcome to another episode of Doodly. This is the video about the actual conduct of low flow anesthesia, which would be the third part of the low flow anesthesia series. Due to the technical reasons, I'm unable to prepare the physics part and the understanding bit of low flow anesthesia in Doodly. That would be posted subsequently as a PowerPoint presentation. At the outset, I have a disclosure for the viewers. What is being discussed in this video is what I have learned over the past 20 years of practicing the low flow anesthesia, of course, with the guidance of my teachers. So you might find this is slightly different from what is being discussed about low flow or the concept of low flow with some other online resources. Before we get down to the finer details of the conduct of low flow anesthesia, there are certain prerequisites which are absolute necessity. The first and foremost being any basic anesthesia workstation with a circle system and carbon dioxide absorber which is reasonably well maintained. The second important thing which is needed is an anesthesia gas monitor which has provision to monitor both the inspired and expired concentrations of the anesthesia agent as well as the oxygen and carbon dioxide. But the most important thing would be the willingness on the part of the practitioner to adopt or practice low flow. If you happen to have access to machines like the GE ACES, Draeger Zeus, or the Macway Flow I or Flow E series of advanced anesthesia workstations, you will not find the necessity of having to go through this video. All you have to do is type in the FiO2 you need, the total flow you need, and the minimum alveolar concentration of the agent. The machine would do everything on its own. This is what is called as the quantitative anesthesia in a closed system. Not having access to these advanced workstations is not the end of the road. Having had all the three prerequisites, namely the willingness to practice low flow, a decent anesthesia workstation, and a gas monitor, we can still practice low flow. How low a flow on the fresh gas can you go down to? Is it an arbitrary number? No. It is principally determined by three important factors, which was the question with which we ended the part 1 of this video. The main prerequisites are, first and foremost, is the oxygen requirement of the patient. No matter what happens, you cannot go down below the oxygen consumption of the patient. The second is the leaks present with the machine and the circle system. The third factor is how the gas analyzer handles the sampled gas. Does it return the gas back to circle system after analysis, or is it vented out? As a numerical example, if you have a patient whose oxygen requirement is 250 ml per minute, you have a 50 ml leak either in the machine or in the circuit, and you have a stand-alone gas analyzer which is sampling 100 ml of gas every minute and is venting it out into the atmosphere after analysis instead of returning it back to the circle system. In this situation, no matter what happens, you cannot go down below a total flow of 400 ml fresh gas flow. Quick recap. Fresh gas flow less than 1 liter is considered as low flow. Fresh gases less than 500 ml qualifies as ultra low flow or minimal flow anesthesia. And if the fresh gas flow is equivalent to the oxygen consumption of the patient, it is called as metabolic flow. The actual conduct of low flow anesthesia, or for that matter, in general anesthesia, is equivalent or similar to flying an aircraft. You have a takeoff phase, a cruising phase, and a landing phase. Now, the takeoff phase can be similar to the initiation of anesthesia or low flow anesthesia. So the cruising phase is similar to the maintenance phase, and the landing phase is the termination phase of the low flow anesthesia. We will be discussing about each of these phases individually in the subsequent slides. Please do note, I will be talking about only the actual conduct. The explanation as to why it is done in a particular way would be part of the second part of this talk. Before we actually begin the individual phases in the conduct, a prelude would help you understand the numbers and things used during the presentation. All the values in terms of the dial settings and the flows, etc., mentioned are for air and oxygen as carrier gas. I do not use nitrous oxide. So, use of nitrous oxide, all these numbers change. I routinely use 6 liter fresh gas flow with 80% oxygen. That would be about 4.5 liters of oxygen, 1.5 liter of air for both the pre-oxygenation as well as the initiation. During maintenance, I routinely use 300 ml fresh gas flow. Of course, it would depend from case to case. I even go down up to 150 ml as well. But generally, I've used 300 ml as the value. With that, we will use about 250 ml of oxygen, 50 ml of air. What this does is it ensures that we meet the oxygen consumption of the patient, and also the actual FiO2 stays around 50% and does not go dangerously low. For initiation, as mentioned in the prelude, I use 6 liter fresh gas flow with 80% oxygen. I set the dial concentration of this fluid to about 6% for about 8 to 10 minutes. Alternatively, you can keep an eye on the agent concentration, the difference between the inspired and the expired agent concentration. Once it drops down to below 1% or less than 1%, you can reduce the fresh gas flow to about 300 to 500. However, the desflurane dial has to be increased to 9% for another 10 minutes or so. At the end of this duration, the difference between the inspired and expired agent concentration would drop down to about 0.5 or 0.6%. At that time, you can reduce the dial concentration of the fluorine back to 6% and maintain it at 6% for as long as you need. This should comfortably maintain the MAC of the patient between 0.8 and 0.9. Now, during the maintenance phase of the anesthetic, the fresh gas flow remains at 300 to 500 ml per minute, the dial concentration of desflurane at 6%. Now, if the surgery goes on for more than 3 to 4 hours or so, depending on the patient's body habitus, the end-tidal desflurane concentration slowly starts creeping up, thereby the MAC also increases. So, this is when we need to dial down the concentration of desflurane to about 4 or 5% in order to maintain the same anesthetic depth. One of the drawbacks mentioned for low flow anesthesia is the delay, the perceived delay in altering the depth of anesthesia, either increasing or decreasing. There are two ways which we can do it. One is increasing the fresh gas flow momentarily, so the change happens quickly. Alternatively, we can use the dial setting itself to make the alterations. Altering the fresh gas flow disturbs the equilibrium which is established and also results in more wastage of inhalation energy. Thereby, it is better to use the dial concentration changes to increase or decrease. If you have to increase the depth, you can increase the dial concentration to either 12 or 18% till the new MAC is achieved. Then you can reduce the dial concentration back down to about 1% above the previous level. Alternatively, if you have to reduce the depth of anesthetic, we can shut down the desflurane vaporizer till the MAC drops down to the desired value, and then restart desflurane at the same concentration as it was earlier. With this, the depth can be altered within a minute or two. During the termination, the desflurane vaporizer can be shut off about 15 minutes prior to the completion of surgery if you are in 300 ml fresh gas flow, or about 10 minutes prior if you are at 500 ml fresh gas flow. With this, the MAC would slowly drift down to about zero point 0.6 or zero point 0.5 over the period of 10 to 15 minutes depending on the fresh gas flow by the time dressing is complete. When you are ready for extubation, reverse the patient, make sure everything is fine, then increase the fresh gas flow to about 6 liters. You should be able to wash out the rest of the desflurane, wake up and extubate the patient in about 3 to 4 minutes. Now, during the conduct of low flow anesthesia, you need to be vigilant about few things. The first one being keeping an eye on the inspired oxygen concentration to make sure that it doesn't drop down dangerously low, resulting in a hypoxic mixture. The second one is keeping an eye on the end-tidal agent concentration, making sure the anesthetic depth doesn't lighten. The last important thing would be watching for gas volume insufficiency. Even though we've done our calculation and set the fresh gas flow appropriately, our calculation might have been wrong, or any of the factors determining the need of fresh gas flow might change during the course of the anesthetic or the surgery. In such situations, the fresh gas flow might become insufficient. In the far left of the screen is a screen of a Draeger Primus machine where you have a visual indicator of the adequacy of fresh gas flow. If the fresh gas flow falls down to the range of deficit, you know you may have to increase the fresh gas flow. Contrarily, if there is no visual indicator in other Draeger machines, keep an eye on the reservoir bag. The reservoir bag would inflate and deflate with each respiratory cycle because of the mechanism of fresh gas decoupling. If the reservoir bag starts collapsing, you know you will have to increase the fresh gas flow because the fresh gas flow may be insufficient. Now, in bellow ventilators or the ascending type of bellows, look for the bellows reaching back to the top of the bottle. If it fails to reach, you know there is a gas volume insufficiency problem. So this would give you a rough idea about the actual conduct of low flow anesthesia or minimal flow anesthesia. Please do look out for the part 2 of the series of low flow anesthesia, where we would explain and understand the reasons behind how the conduct was conducted. Thank you.